I'm introducing Dr. Thomas Masterson out of U Health in Miami, and he's going to bring the hypogonadism, low testosterone conversation here for you guys. Go ahead and Tom, take it away.
All right, fantastic. Thank you for the introduction. So every good Zoom talk starts off the same. Can you guys see my slide?
Yes, we can.
Perfect. All right. So I'm a little bit hoarse. I woke up this morning with a bit of a cold, so if I have to stop every once in a while and take a cough drop or sip of water, I apologize. But so yes, I'm a urologist. I practice down here at the University of Miami in Miami, Florida. And my particular practice focuses on sexual medicine, which includes uh, testosterone replacement, erectile dysfunction, and other men's health topics. So today's topic is going to be on specifically testosterone. So we're going to cover what exactly is low testosterone and hypogonadism. What are some of the long-term consequences of low testosterone? Then we're going to discuss the replacement options, the goals of testosterone replacement, and then touch a little bit specifically on cystic fibrosis and low testosterone. So I'm sure all of you are aware of this, but the average life expectancy of a patient with cystic fibrosis has increased drastically over the past 25 years, to the point where cystic fibrosis is no longer really a disease of young people. It's become chronic disease. And with that, patients with CF are suffering from all of the other chronic diseases that the rest of people who live into their 60s and 70s experience. So what does this mean? At some point, cystic fibrosis is going to be something where you're just like everybody else, but you've just got one aspect of your health that is something that needs to be monitored. So what about low testosterone? So first, what exactly is testosterone? Well, it is the sex hormone for men that is derived from cholesterol that is primarily created from the testicles. Now, since Ruben talked that you guys have had some discussion about other hormones, my quick soapbox on testosterone therapy, which is counter to a lot of my colleagues, is unlike other hormones, testosterone's a little bit different. If you do not have, say, insulin, right, you'll be a diabetic, sure. But if left untreated, you're going to die pretty quickly. Similarly, if you do not have thyroid hormone, you will eventually die. If you don't have cortisol, you will eventually die. If you do not have testosterone, you will just live a long, miserable life. So testosterone isn't really required for you to live, but there are long-term consequences of low testosterone. So testosterone is important for male sexual organ development during puberty, as well as in utero when the fetus is developing into a male. And it is involved with bone growth and strength, libido, which is the desire for sex, muscle growth, and sperm production. Off to the right here, you can see the regulatory mechanism, which we'll focus on in a moment. So where exactly is testosterone made? Even though testosterone is the male sex hormone, women do also produce testosterone. In men, 95% of the testosterone is produced from the testicles, and about 5% comes from the adrenal gland. And normal testosterone levels in men range between 300 to 1,000 nanograms per deciliter. In women, it's about 50-50. Testosterone comes from the adrenal gland or actually from their ovaries. But you can see that it's an order of magnitude less is what the normal levels would be, only between 15 to 70 nanograms. So how is testosterone regulated in the body? This is important, this slide, mostly to understand how this whole system works. But the hypothalamus basically monitors your testosterone levels, sends a signal to the pituitary, which in turn sends the signal LH to the testicles, specifically to the Leydig cells, to then create testosterone. And there's a feedback mechanism so that as the testosterone levels increase, that signal starts to decrease. The best way to think about this is like a thermostat in your house and the heater. The thermostat is constantly monitoring the temperature of the room. And when the room gets cold, it sends the signal to the heater to turn on. Just like when the testosterone levels drop, the brain sends a signal to the testicles to increase the levels. And that is basically how your body regulates your testosterone. Now, in development, there are some critical periods that help testosterone, like help the fetus basically, or a person develop into a male. So prior to birth, there's a high spike of testosterone levels, basically when the undeveloped gonads are starting to develop and the undeveloped sexual organs are starting to develop. Without that peak, a fetus will basically develop into a female. And this is sort of washing over a lot of the details, but just to give you a little bit of an understanding. As we age, as we go through childhood, our testosterone levels remain fairly low. But once we hit puberty, they start to spike. From that point on, your testosterone levels will pretty much be leveled off until you hit your 30s, where they actually start to naturally decrease, on average about 1% per year. And you can see that there's a pretty wide range of what's considered normal. When we look at testosterone levels on a daily basis, it follows a circadian rhythm. And what that means is that naturally, men's testosterone levels are not at a constant level, but they actually spike in the morning and then start to decrease throughout the day. This is more prominent in younger men. So for young men, we expect much higher levels in the morning with much lower levels in the evenings. And as we age, this diurnal secretion starts to blunt, but still highest in the morning, lowest in the afternoon. So how do we define the pathology that is low testosterone? So we saw how much variability there is in testosterone levels. We use the morning peak levels to determine whether or not there's underlying pathology. So low testosterone is defined as biochemically low testosterone, defined as 2 properly collected morning symptoms with symptoms, okay? So what are the symptoms? Over here on the right, you can see some of the common ones. This is reduced energy, reduced endurance, diminished work performance, diminished physical performance, loss of body hair, reduced facial hair growth, fatigue, loss of muscle, obesity. This can also be associated with depressive symptoms, cognitive dysfunction, reduced motivation, poor concentration, poor memory, irritability, reduced sex drive, and reduced erectile function. Now, looking just at those symptoms fall into a lot of other categories other than hypogonadism, such as depression, low thyroid, sleep disorders. So just because you have symptoms doesn't necessarily mean it's a testosterone problem. So what is considered biochemically low? Well, that depends on who you ask. If you ask the Endocrine Society guidelines, they use the strictest cutoff of about 264 nanograms per deciliter. If you do the American Society of Men's Health, they use a cutoff of about 350. But what's important is it consistently low and are you symptomatic? So once we've said, okay, sir, you have low testosterone, right? You've got symptoms, you've got your low levels. We further classify it as either primary or secondary. And this has to do with where is the problem in that whole testosterone secretion process. Primary is pretty simple. The concept is the testicles don't work because the problem's with the testicles. A simple way to define this would be, imagine somebody who had to have their testicles removed, right? The testosterone is very low. The brain works just fine, so it's sending that signal. So we see low testosterone with a very high LH. LH is that signal, right? Think of it, if your heater broke, the thermostat is still sending the signal telling the heater to work. The heater is just not doing anything. In secondary low testosterone, the problem is now centrally with the brain, where the testicle is just not receiving the signal. So what we see here are low testosterone levels with either low LH or inappropriately normal, right? We would anticipate if the testosterone is low, the LH should be high because it's your brain should be telling the testicle to work harder. Secondary is when we want to look for other causes, right? We're not just blaming the testicles. So it's important to get additional workup. And typically we'll look for things like elevated prolactin. We'll get a brain MRI to see whether or not there are small benign tumors, which may be preventing the secretion of LH. Patients with secondary may also have obstructive sleep apnea, or things like hemochromatosis, which is an iron overload syndrome. So other causes of low testosterone, we do know, as said earlier, testosterone decreases with age, about 1% per year once you hit your mid to late 30s. And you can see that when just looking at average testosterone levels of men by decade. But there are certainly other things that can cause it. We know that men who have more chronic illnesses are more prone to low testosterone. So things like hypertension, high blood pressure, diabetes, obesity. There are some genetic syndromes such as Klinefelter's, where you have an additional X. But generally speaking, if you remain healthy, your testosterone levels should pretty much maintain throughout the entirety of your life. So what are the benefits of testosterone therapy? Well, symptomatic relief for one. So we look for things like increased erection quality, improved libido, improvements in anemia, increased density of bone, increase in lean body mass, and improvement in depressive symptoms. So how do we treat low testosterone? Well, first, try to fix whatever the underlying problem is when you have something identifiable. For men who are at that borderline, who are maybe a little bit overweight, who smoke, who drink too much, right? Trying to get rid of those unhealthy habits can increase your testosterone levels. For people who have very bad sleep schedules, because they're either getting up at night or they stay up late, or they're using a lot of caffeine, things that are like stimulants, try to reduce those things, improve their sleep hygiene. So diet, exercise, stress reduction, these are all the non-medical interventions that may improve your testosterone levels. And again, this is going to be for people who really have secondary low testosterone. Again, if the problem's with the testicles, the answer is simple. It's just you give testosterone. There's nothing you can do to really fix it. And then for patients who have other concerns, such as who are considering fertility, this is in another talk, but testosterone therapy is a contraceptive. So for men who are interested in fertility, we use other off-label medications, such as HCG, selective estrogen receptor modulators, and aromatase inhibitors. And then our last option there is obviously testosterone replacement. So counseling, remember, testosterone replacement therapy, giving somebody testosterone does not fix the problem, right? It's replacing what you're missing. So it's never, so people will ask, when I start testosterone therapy, when can I expect to stop? The answer is really never, right? You're going to be on this potentially for life as long as you're having benefit from it. Now, I actually have to change this slide as of last week, but there was an FDA warning on testosterone therapy that is in the process of getting removed, that testosterone can cause an increase in heart attack and stroke. There was recently a huge trial published last year basically refuting this, so much so that the FDA is now removing this as a black box warning. But it is still contraindicated in patients who have active breast cancer and active prostate cancer. All right, so what are our replacement options? So this is by no means an all-inclusive list, but I include this one slide to show you these things so that you can just kind of take a screenshot and have at least a baseline. But probably the most well-known is intramuscular injections, where you actually inject yourself with the testosterone, usually every week, potentially twice a week or every other week. For my patients, the starting dose, pretty much for everybody, is 100 milligrams or half a cc of testosterone cypionate every week. Common side effects right? Common side effects of all testosterone therapies include, increased hematocrit, acne, gynecomastia, but things that are more specific to injections are increases in hematocrit and obviously like injection site reactions. Because it is in an oil and it's fairly viscous, some people can have an allergy to the oil. Also, things to just monitor when on therapy. Transdermal gels also have been around for a very long time. The way they work is they get absorbed through the skin, and then your subcutaneous fat becomes a reservoir for the testosterone. So the first day that you put it on, you may not notice a ton, but over about a week, and it finally builds up in your system. I start most patients on the 1.62% with 2 pumps a day. Things to consider with the testosterone gels are that they're gels. They're a little bit messy compared to other forms. When you apply the gel, you want to apply it to a skin that is fairly hairless, as it won't absorb very well on a hairy surface. And it needs to be somewhere that is covered, because if you apply the gel, to say your hands and you touch somebody, you're going to then give them a dose of testosterone. So I recommend applying it to the upper back, the shoulder, the thigh, someplace that you're going to be wearing clothes. Unlike what we talked about, none of these are going to mimic our normal circadian rhythms, but they try to give you at least enough testosterone that you are improving your symptoms. So you're not going to have the daily peaks and troughs. With the injections, you kind of get more like a weekly peak and trough. With the gels, you kind of get more of like more of a steady state. You're never quite as high or quite as low as you would be normally. One of the newer formulations is nasal gels. The way they're delivered, and it is a gel, it's not an aerosol the way most people think it will be. It's not like a spray in the nose, it's more like you're painting the inside of your nose. This is basically 2 pumps, one on each side, twice a day or 3 times a day. Compared to both the gels, the transdermal gels, and the injections, this has less of an effect on hematocrit, tends to have less of an effect on sperm production problems, but it can give you things like rhinitis or postnasal drip, which can be frustrating for patients. Also, one of the newer things, oral pills. So the pills of like the 1980s, they had a problem because when you take testosterone orally, it gets absorbed into your GI system and passed through the liver. As a steroid, the liver does not like it. So the old pills used to give problems with basically hepatitis. You get like a transaminitis. The new ones are developed so it actually gets absorbed through your lymphatic system. So the pills you take twice a day, usually with a meal, so that it gets easily absorbed into your system, and titrated up or down. Like the gels, the nasal gel, it has less of an effect on your hematocrit, and it may have less of an effect on sperm. There's some studies looking at this right now. But you have to take them twice a day, potentially more than just the one pill twice a day, but several pills twice a day, which can be frustrating for patients. And then our last option here is subcutaneous pellets. So these pellets actually go usually in the butt, under the skin. It's a minor procedure, takes about, call it 10 minutes. We usually start you anywhere between 8 to 12 pellets, and they last for about 4 to 6 months. The nice thing about these is you don't really have to worry about giving yourself injections, taking your pills, whatever, because they're in there and they're going to slowly dissolve over time. The downside to it is if you have any side effects from it, they're kind of stuck in there, and you have to have a small surgical procedure to have them removed. But if there's something you've tried others and you've tried other modalities, a lot of patients like this because, again, they come into the office, they get their pellets, they don't think about it for 6 months. Now, insurance coverage for many of these things is quite spotty. And I get in a lot of shouting matches with patients. I shouldn't say shouting matches, but I deliver a lot of bad news when they get an insurance denial. But the good news is these are not really all that expensive if you go through commercial pharmacies using the GoodRx coupons. So injectables cost you basically around $35 a month. The gels, $45 a month. So even if your insurance doesn't cover it, it's still fairly affordable. So there are options out there. So once on therapy, what do we monitor? Well, the first thing is symptoms. Beyond anything else, I'm mostly concerned about whether or not you feel improvement, because that's what got you there to begin with, right? Unlike your cholesterol, which is screened by your primary care, testosterone is not something that is routinely screened for. So patients usually present with some symptom that then leads to a lab study. The second thing is side effects. Are you having any sort of adverse reaction to the delivery system? Are you developing gynecomastia? Are you developing acne? Is your hematocrit increasing? Is your PSA increasing? So we want to also monitor those things. We get hematocrits on you every 6 months. We get PSA as age appropriate, generally yearly intervals. And the goal for the testosterone level is really above 450. 450 is considered the middle tertile. Now, if I have a patient who their testosterone level has gone to, say, from like the 200s to, say, the low 400s, but they feel great, I'm not going to change their therapy, right? Now, let's say their testosterone's gone up to the thousands and they say, Doc, I'm still tired. I still don't have any erections. I'm still unmotivated. Well, then we need to look at something else and say, look, this is probably not a testosterone issue. There's probably something else going on here. Once I start patients on therapy, I usually check their labs about 1 month after they start any new testosterone or any adjustments to their testosterone. And then once they're on a steady state, we check every 6 months. So testosterone at a federal level, meaning at every state, it is a controlled substance. It is a Schedule 3. I believe it's Schedule 3. What that means is we can only give you a 6-month supply at a time, which is a little bit annoying. And I think in some states you have to have at least one in-person physical exam. I think that's that stuff. All right. So what are some specific situations? So testosterone and PSA. So PSA, it's a screening test for prostate cancer. Sparing you guys like the long history of it, suffice it to say that at least in the past, we've really believed that testosterone fuels prostate cancer, right? Or potentially even causes prostate cancer. So a common situation is you have patients, right, who once they start their testosterone, their PSA may elevate. Now, how we handle this situation is a little bit controversial because there's no real standard of care on it. Some people believe that in a guy with low testosterone, right, if you put them on testosterone therapy and bring them up to normal levels, their PSAs should increase because we know that the prostate is very sensitive to testosterone levels and that this is just a normal response. Others believe that this may be a sign that there was an underlying undiagnosed prostate cancer and it needs to be further worked up. So we have to kind of handle this situation somewhat carefully. If you find yourself in this situation, I highly recommend that you reach out to a urologist if you're not seeing one for testosterone therapy, because you don't want to miss, an undiagnosed underlying prostate cancer. So what about testosterone therapy after prostate cancer treatment? Again, in the past, we believed that this was a bad thing to do, that testosterone may bring their prostate cancer back. We now recognize that this is not the case. Once prostate cancer is treated, either with surgery or radiation, as long as their PSA responded, that blood level, it's generally safe to put somebody on testosterone. For patients on active surveillance, which means they've been diagnosed with prostate cancer, but it's very low grade and very unlikely to cause them any problems in their life expectancy, it's still controversial whether or not to give that person testosterone because there may be that risk that the testosterone will cause that prostate cancer to grow more quickly. Now, switching over to specifically low T and cystic fibrosis. So low testosterone affects somewhere between 2 to 12% of men in the United States. And as we said, low T increases as men age. However, in the cystic fibrosis population, it appears that the incidence of low testosterone is much higher, depending on what studies you look at, anywhere from 25 to 88%. And that's a pretty high percentage, right? Some other interesting little facts are that historically, in boys with cystic fibrosis, puberty was delayed in about 20 to 60% of them. The reason being that their testosterone levels were not increasing at puberty the way you would expect. However, it appears that as therapies for cystic fibrosis have improved, this difference has actually started to diminish. So that's good news. But what are these possible causes of low T in this patient population? Well, the first is likely malabsorption. So part of the syndrome of cystic fibrosis is pancreatic insufficiency. And pancreatic enzymes are helpful in digesting fats, and therefore the fat-soluble vitamins. Another issue could be recurrent infections requiring antibiotics. Antibiotics can change your gut flora, which again change your absorption of vitamins and minerals. Chronic steroid use. So in other patients who are on chronic steroids, they by themselves will actually decrease your testosterone levels. There may be also some disruption in GRNH secretion, and possibly low T may just be a side effect of some of the medications. So again, this is just a list of some of the end organ problems that are part of the cystic fibrosis basically spectrum. Now, despite cystic fibrosis may be having by itself issues with testosterone, it is important that when working up patients with low T, regardless of other medical comorbidities, that you just stick to the basics. So this was a case report of a patient with cystic fibrosis who had low testosterone. They checked his levels. His testosterone came back quite low at 175. When they checked his LH, it was normal, which we discussed earlier is inappropriately normal, because with low T, we would expect the LH to increase. They appropriately then checked a prolactin to find that this particular patient had a small pituitary tumor called a prolactinoma. Sometimes these require surgery. Other times, like in this case, they were able to treat with a medication called cabergoline, which then decreased the prolactin, shrank the tumor, and got the testosterone levels back to normal. This would be an instance where if you just put this patient on testosterone therapy, you could miss a potentially life-threatening diagnosis. So with cystic fibrosis, there's also this condition called cystic fibrosis-related bone disease. It's not quite clear why exactly this happens, but we know that, again, because of the issues with the pancreas, there are problems or issues with fat-soluble vitamin absorption, which includes vitamin D, which is important for bone health. Additionally, when your body does not absorb fat in your GI system, fat tends to bind calcium, and therefore you'll just poop it out. Calcium is also a mineral heavily involved with bone formation. In patients who do not have cystic fibrosis, testosterone therapy increases bone mineral density. However, studies are lacking in the cystic fibrosis population as to whether testosterone replacement does help with this cystic fibrosis bone-related disease. So it is something for future studies. So Ruben knows this stuff because this was a part of his talking points in the past at the AUA. But shockingly, right, men with cystic fibrosis, despite having low testosterone, are actually less often prescribed testosterone replacement. So this was a study actually done at our institution using a very large commercial database, looking specifically at patients who had a diagnosis of cystic fibrosis or congenital bilateral absence of the vas. Now, you may be asking why we compared those two patient groups, because congenital bilateral absence of the vas, CBABD, is caused by a cystic fibrosis mutation. They are patients that have one series of the mutation, not two. So they don't have CF, right? They're carriers. But interestingly, those patients were prescribed testosterone replacement more commonly than patients with CF with low T. Now, some other just special sort of interest populations. So do testosterone levels change after lung transplant? So this was one of my colleagues using the same database. It was looking at lung transplant recipients to see whether or not patients' testosterone levels increased after replacement. Well, overall, right, when they looked at pre and post transplant, there wasn't much change. The patients who had low testosterone beforehand, their levels actually did improve. Now, in this study, there were no cystic fibrosis patients specifically. Again, from that same group, they were looking at just all solid organ transplantations. Is testosterone potentially protective? So in their study, they found 87 patients who had a solid organ transplant and a diagnosis of low testosterone. 58% of them were 58 of those patients were treated for their low T, 29 were not. And what they actually saw is the patients with low T who had an organ transplant, whose low testosterone was treated, actually had longer survival than those who didn't. So it is possible that testosterone therapy does actually help in the post-transplant population. And to follow up on this study was that there was basically otherwise no difference in other types of outcomes, such as prostate cancer, hematocrits, things that are generally associated with testosterone. So basically, the testosterone was helpful without a lot of adverse events. So in summary, low testosterone is as likely or more prevalent in the CF population, and testosterone can potentially improve quality and quantity of life. And if you find yourself in that unfortunate situation where you need an organ transplantation, testosterone therapy may be beneficial. So with that, we will take questions.
Tom, thank you so much. Before we go into the general Q&A, I actually have a couple of qualifying. I apologize for my lighting. The sun went down on that side, and I haven't had a chance to turn the other lights on, so I'm very orange. But I wanted to clarify a few things. I was taking a couple of notes for myself. Hopefully, everybody that was here, if you have questions, we want to get to them. So keep those there, or you can even start putting them in the chat on the side. But I had a couple of questions specifically about some of the topics that you talked about, and then I wanted to highlight a few things. There are some really, really cool stuff. I'm a lung transplant patient. Not everybody here knows that. I should have said that. I'm actually coming up on 6 years. So the protective factor of T is a really exciting thing. We're going to get to your guys' questions in just a moment because we're going to actually stop the recording. So we're currently recording. So for confidentiality, I'm just going to put a couple of questions out here for clarification. Then we'll stop the recording, and then we'll open it up to your guys' questions here. So a couple of things that I wanted to call out from your presentation. One of the things is the bone loss conversation. That is obviously it's a huge issue with CF patients in general. The concerns of osteoporosis, osteopenia, malabsorption, a lot of those interactions with calcium and vitamin D. CF patients are generally chronically low in vitamin D, which is another factor, which we actually talked about in the last session, and actually the first session, in that vitamin D being a hormone transport. So if your vitamin D is low, that can be affecting your testosterone and really all of your hormone levels in adverse ways. But I'm actually my own case study in bone density. It's one of my talking points, has been in the past at AUA. I have a DEXA scan history, as most CF patients do, and I was in dangerous territory with my bone loss. Had fairly advanced osteoporosis and also osteopenia in other marker areas that I didn't have more advanced. So far that they were starting to recommend pretty drastic measures prior to my transplant. I started testosterone therapy. I did get a lung transplant, but we know that that doesn't generally change bone density. In fact, being on long-term prednisone is actually
Mm,
a detractor of that. So theoretically, I should either maintain the same amount of bone loss or it should continue to decrease. In 3 years of testosterone therapy, I'm now going on almost 7 years. In the first 3 years, I reversed all of my bone loss, skeletal wise, all the way back to baseline. And actually, now I'm considered in the 103 percentile for quality of bone health and bone density.
wow.
And the only thing people said, well, your diet changed, your exercise, nothing changed as far as my gym time, my training, my nutrition has all stayed fairly similar to what I was doing post or pre-transplant. The only new factor is testosterone. And so I've had a huge success in that space, in addition to sleep cycles improving and just a number of other things. So I really wanted to highlight that. While there may not be studies out specifically for CF patients, I can say
Yeah.
anecdotally, in my case, it made a massive difference. So much that it was raising eyebrows in the CF medical community. And so that's a really exciting outcome. And more, we're talking about aging CF patients. In fact, I have a friend that just the other day is on Avastin for bone loss. And it kind of broke my heart because he's one of those ones that I know that has never been treated. And I've talked about this with him about conversation around testosterone. It hasn't worked out or he hasn't moved forward in that. No judgment there. But seeing that he's on some pretty severe treatments for it, it's like, man, there might have been some other opportunity. I don't know if that's the case or not, right? Speaking anecdotally. One of the questions I wanted to ask you, you mentioned it multiple times, but can you clarify for everybody here when you talk about increasing hematocrit
Oh,
levels? Like,
yeah.
what does that mean?
Yeah, so it's your red blood cell count. So the mechanism behind this, in my opinion, has never really been all that well like explained to me. But we know that people who are on higher levels of testosterone with less frequent dosing tend to have their red blood cell count increase. Now, whether this is a bad thing or not is also super controversial, but we do treat it. So a little bit confusing is, the FDA had this black box warning about heart attack and stroke. We kind of assumed that this increase in hematocrit may be part of that whole issue. But this big clinical trial that they just did, the two things really didn't line up. So what we typically will do is if your red blood cell count gets too high, we usually just have you donate blood, or we'll dose it, or we adjust your testosterone level, or change the way that we're giving it to you. So if you're like on injection, switch to gel, things that have less of that as a side effect.
Now, would you say, in my case, I actually was fairly low level prior to transplant and prior to starting testosterone. The increase actually improved my health to a degree. I've leveled
Yeah.
off. It's not continued to increase. Can that be a benefit? Is that something that you see?
Oh yeah. Yeah. So I mean, there are side effect profiles, right? That's a side effect that is like we use it sort of advantageously. So
Okay.
if somebody comes in and part of their low T symptoms constellation is anemia, right? Low red blood cell count, then yeah, injections can potentially, fix that issue. So for
Okay.
the most part, like when I'm prescribing testosterone, it's mostly like which one do you want to try? Because none of them are really any better or worse than any other. But you can use those side effect profiles, to your advantage in certain situations.
Awesome. So I'm going to stop. Doug, if you're able to, if you can stop the recording now. Thank you for those that are watching. You can get more on other sessions by going back in previous videos. We're going to go ahead and stop the recording now.